An introduction to ABFT. What is ABFT? Also known as attachment-based family therapy. It is a therapeutic model designed to treat adolescents struggling with depression, trauma, and suicidality by repairing and strengthening the emotional attachment bonds between them and their caregivers. Rooted in attachment therapy, ABFT aims to improve family communication, rebuild trust, and resolve relational conflicts that contribute to the adolescent's emotional distress. The therapy follows a structured 5-phase process focusing on building alliances, repairing ruptures, and fostering both emotional closeness and autonomy within the family.
ABFT was founded in 2002 at Drexel University by Guy Diamond, Suzanne Levy, and Gary Diamond. Suzanne Levy stated that every parent has good intentions but may often misunderstand their children. ABFT aims to resolve that. Guy states that ABFT is rooted in attachment theory, which states that early childhood experiences determine your psychological strengths and weaknesses, which can be strengthened by functioning parent-child relationships. Goals of ABFT are to strengthen emotional connections between child and parent and encourage an emotional communication. And it's also intended to heal emotional wounds with the guidance of a therapist. There are 5 phases within the treatment structure. The first one, relational reframe. It shifts the focus from individual problems to relational issues, highlighting the role of the family attachment in the adolescent's distress. Alliance building with the adolescent. The therapist forms a strong bond with the adolescent, helping them express their pain and prepare for family repair work. Alliance building with the parents. The therapist engages parents in reflecting on their role and prepares them for reconnecting with their adolescent emotionally. Attachment repair. The adolescent and parents engage in emotionally focused conversations aimed at healing ruptures and restoring trust in their relationship. And then 5, the last phase, promoting autonomy. The adolescent develops autonomy and self-confidence while maintaining supportive, healthy family connections as relationships improve. Overall, the goals of ABFT are to strengthen those family connections, especially between parent and adolescent, while also working towards diminishing the suicidal ideations, depression, and anxiety within the adolescent themselves. For ABFT is parents and adolescents ranging from ages 12 to 24. ABFT is beneficial for many different caregiver-child dynamics, such as single-parent households, blended families, and two-parent households. It is also beneficial for cultural diverse families, such as immigrant families and those that were not raised in a westernized culture. It's designed to improve depression and suicidal ideations in adolescents and help heal emotional estrangement and family conflict. Assessment tools that can aid in ABFT and work in tandem with it, such as genograms, the Beck Depression Inventory, suicidal ideation questionnaires, and family environment scale. Genograms are especially helpful with ABFT as they visually break down a family's mental health, medical, and generational history, helping identify points of concern and for understanding why there may be discourse within the family. The Beck Depression Inventory and Suicidal Ideation Questionnaire are other tools that are useful in helping to determine the severity of depression or suicidal ideations in an adolescent. While ABFT is relatively new in comparison to other therapies, it does have empirical evidence to back it up. One such case being Santisteban, in which the study found that ABFT was effective in significantly reducing depressive symptoms in adolescents in Latinx families. It demonstrated that ABFT could successfully be adapted for cultural diverse populations. Over the years, ABFT has been put through many studies that show its effectiveness.
Ethical considerations in ABFT revolve around maintaining confidentiality, ensuring informed consent, navigating complex family dynamics, and being culturally sensitive, all while prioritizing the safety and well-being of the adolescent. Therapists must be aware of these challenges and handle them with care. To dig deeper into some of the ethical dilemmas, risk and harm in mandatory reporting was a major one that I came across. It it is very important that therapists understand going into these therapies that they are handling children and adolescents that have suicidal ideations, and there has to come a point where you may have to make a decision on whether or not the therapy you are giving the child is enough for what they need. If the child is at risk of harm, continuing the therapy in lieu of inpatient therapy or some other form of therapy may cause an ethical issue. Touching on cultural competence, gender roles and expectations, and religious beliefs and practices, especially for those clients of ours that are not from a westernized culture, gender roles may be far different and may be ingrained in the parents' upbringing, especially if you have children who are first generation American and their parents came here for a better life or whatever reason they came here for. Working with those families could cause strife and bring up some ethical dilemmas as well. There are many challenges with ABFT. An important challenge to consider with ABFT that I found is that it is often meant to be delivered in a brief, time-limited format, usually 12 to 16 sessions, and some families may struggle to achieve meaningful progress if there is deep-rooted attachment issues or complex family dynamics are involved. A shorter duration might not provide enough time to fully address all the issues or allow for lasting changes. ABFT can also be highly emotional. It involves deep emotional work and can bring up painful memories and unresolved issues. If not carefully managed, this emotional intensity can lead to increased distress for both the adolescent and their parent. The therapist needs to ensure that the process is paced appropriately to avoid overwhelming the family members. And there's also a risk of relational ruptures. On top of all of that, we do have limited empirical evidence about ABFT. There is empirical evidence, but in comparison to other practice therapies, it's very small, especially since it has only been around since 2002. In conclusion, attachment-based family therapy is effective, evidence-based intervention designed to treat adolescent depression, suicidal ideation, and trauma by repairing and strengthening attachment bonds between the adolescent and their caregiver. The therapy focuses on improving communication, emotional expression, and trust within families, leading to significant reductions in depressive symptoms and suicidal ideation. While attachment-based family therapy has shown strong effectiveness, challenges such as family resistance, emotional intensity, and cultural adaptability can limit its success. Despite these challenges, attachment-based family therapy remains a valuable approach for addressing adolescent mental health issues, particularly when relational factors play a central role in the adolescent struggles. I have two thought-provoking questions. Number one, how do you think ABFT can be useful in situations where there are external stressors, such as financial problems, substance abuse, or other issues that impact the family's ability to engage with the therapy? And number two, in cases where parents aren't willing to fully engage in the process due to their own unresolved trauma or emotional barriers, what strategies could a therapist use to ensure progress in ABFT? Thank you.